medical homes and young children, improving healthy development and closing health disparities. Our distinguished guest is Dr. Charles Bruner. He's the Director of Research and Evaluation for the BUILD Initiative with the Child and Family Policy Center. Welcome. We're so happy to have you from all over the state. We're not going to ask you to introduce yourself, but we do have several people in the room here in Denver, and perhaps later Dr. Bruner will want to know who he's speaking with, but and we'll have a question and answer period after his presentation, and so I'd like you to introduce yourself at that time. Annie, do you want to talk about how to chat in the chat room? We'll take questions during the presentation through the chat room. This is Annie Guo, and she's going to tell you how to do that.
Okay, hi. So in the webinar, you should see a chat function, and Laura and I are here to facilitate the questions. So if you have any questions or comments throughout, you can type them in, and then we'll take the questions throughout the presentation and then again after. Okay, thank you.
So again, our distinguished guest is Dr. Charles Bruner. He serves as the Executive Director of the Child and Family Policy Center. He served 12 years as an Iowa State legislator, and through the Child and Family Policy Center, he provides technical assistance to states, communities, and foundations on child and family issues, and heads the technical assistance activities of the federally established National Center for Service Integration. Through funding from Ford, Kauffman, and Packard Foundations, he also directs the State Early Childhood Policy Technical Assistance Network, providing evidence-based assistance to state decision makers on school readiness issues. Charlie has written widely, not wildly.
Maybe also wildly.
Maybe wildly and widely on public policy approaches to developing more comprehensive, community-based responses to child, family, and neighborhood needs. Welcome, Dr. Bruner.
Well, thank you very much. I'm very pleased to be here and be able to present some of my perspective, and some of it's been from learning from your work in Colorado and from your leadership. And I'm really excited about your work really to emphasize medical homes and a broad approach to early childhood systems building that does involve the health community. And so I'm going to go through an overview presentation about where I think nationally we are in terms of medical homes, and a little bit of a conceptual framework around where how this is playing out, and hopefully provide some real-world examples and context, and then go into a little about what the federal funding opportunities are, and where we really have an opportunity of making a difference. So the first, and you doubtless all know this, but for those trying to set the stage, we do know the science of early childhood and school readiness, and we have a great deal more information now than we had 50 years ago, though even 50 years ago we knew that the first years of life were very important. We know that learning begins at birth. We know that the early years are critical to healthy development and educational success. And I think that increasingly I say that if we want to affect an individual's health, the first 1,000 days are probably the most important time for doing so, not the last 1,000 days. And in particular, the growing body of research on toxic stress, early childhood adversity, the developing literature on bonding and attachment, brain research, and epigenetics really points to the birth to 3 years as really critical foundational ones in setting the trajectory for health and well-being. And this is the time when we have a great opportunity. And it's also the time when I'll speak to this later where the health practitioner community in some ways can play the greatest role. We know that healthy development and school readiness is in fact multidimensional, and these things all fit together. You can't quite segment a child into different parts, but it's language and literacy and physical health and motor development, general cognition, social emotional development, approaches to learning, and all those interact as far as a child's going to school ready to learn, healthy and prepared for success. And certainly if a child has untreated medical conditions, they are not going to be in the position to learn and benefit from classroom. But we really do know that if a child is experiencing trauma, that affects what their approaches to learning are, their psychological set, it affects their physical development, it probably affects their language and literacy development as well. So that these are all features of healthy growth and development, but they also are highly connected to one another. We also know that child health itself, healthy child development is multidimensional, and it involves, as the next slide will show, genetic, biomedical, social, and environmental factors. And this slide, which is taken from Healthy People 2010, but it also really does relate and as far as what are the contributions to children's health, that we know that adult health and children's health is really, medical services play a role, but a fairly small role in overall health behaviors and actual health conditions, and perhaps 10% environmental factors, and that can be around physical environmental hazards and hazard and safety factors contribute more. Obviously, a child's own genetics and makeup have a contribution. All children are unique, and some have special health care needs and conditions or other conditions that are going to affect their health no matter what we do, although early intervention and response often can be very helpful to them. And then healthy behaviors, which for when we're talking about kids, and particularly young kids, it's really about the child in the context of their family and what's going on with their family and how the family is connecting with them and being the child's first teacher, nurse, safety officer, and guide. And so we know this. Now, I mentioned that the medical services only play 10% of that. That doesn't necessarily mean that the health provider's responsibility is only for 10%. And we'll get into more of that later. There's a lot more literature and international literature as well as literature in the United States around these environmental factors and health behavioral factors. And we know that social determinants are critically important to child's healthy development and to the health of the population overall. And this is taken from Social Determinants of Solid Facts, which is international. I think it's UNESCO commissioned it, but these 10 factors they point to about contributors to health, including the social gradient or income inequality, stress, early life, social exclusion, work and the way work is constructed or people have work, unemployment, social support, addiction, food, and transport. And these all are part of social factors that really represent that 80% that's around social determinants of health. And the definitions is going a little bit on selective one. Social gradient is life expectancy is shorter and most diseases are more common farther down the social ladder. And in addition, the more inequality of income and the inequality of access to resources within a country, the worse the overall health is going to be. And when people not only are at the lower end but don't see any opportunity for advancement and feel like that they are stuck in the lower levels, that's deleterious to health. Early life, a good start in life means supporting mothers and young children, the health impact of early development, educational lapse a lifetime. I was fortunate to be able to go to a UNESCO conference in Moscow 2 years ago, which was on building the wealth of nations, and it was all about how can we reach the millennial goals around health and school readiness for children. And it really spoke to early life as being key in developing countries as well as the developed world as far as building wealth and addressing a whole variety of concerns. Stressful circumstances making people feel worried, anxious, and unable to cope, or damaging to health. And I think, again, there's a lot more medical research and knowledge about the effects of stress. And certainly Jack Shonkoff's work with the Center for the Developing Child when he talks about the tremendous damage of toxic stress, or stress that's really constant and unmitigated in young children, as having hugely harmful impacts. Social exclusion, we just came back, some of us were at a conference on health equity in young children, and the fact that social exclusion, which can be discrimination by race, ability, gender, and a variety of things, causes hardship, resentment, poverty, and social exclusion. And of course, those who are socially excluded and marginalized, one of the big things is it produces stress. Again, that those two are related. And social support, that friendship, good social relations, strong supportive networks improve health at home, at work, and in the community. And how we try to build within our human service interventions things that not only provide professional services and supports, but ensure that people are connected up with other supports for them. Many of you are probably familiar with Strengthening Families work that Center for the Study of Social Policy has done with Doris Duke Foundation. They've identified 5 factors, protective factors, that are key for child abuse prevention, which are also key to healthy child development generally, and also really do represent these. And those 5 include social support both for the families and the parents, and social supports and positive social environments for the children as 2 of those 5 protective factors. The others are parental resiliency, which also is related to the parent's sense of confidence and competence in parenting, and the sense of confidence and competence in social relationships, concrete services in times of need, and knowledge of child development. So wanted to kind of emphasize that we have this literature, and we know that we need to address these social determinants for a lot of young children and their families. And it's not just providing medical care. And the concept of a medical home really originated within the pediatric community. It's probably been as much or more used for chronic populations of adults as it has for kids. But it was really designed as a medical home that would take a whole child, a family-focused approach that would recognize and work to respond to those social determinants. This slide, and you may have seen this slide before, and it's been differently configured, and I think you have something very similar to this in Colorado in your framework. But what it tries to show is that we know for children to progress in early childhood, to start school healthy and prepared for success, they need to have health, mental health, and nutrition, good health, mental health, and nutrition, which means comprehensive health services that meet their vision, hearing, nutrition, behavioral, and other needs. We also they need to have strong early learning environments, which can be both formal and informal, but early care and education and nurturing environments where children learn what they need to succeed in school, and develop developmentally appropriate guidance. We know that they need family support or economic and parenting supports to ensure that children have nurturing and stable relationship with caring adults. And we know that for a small subset of kids, there's a need for early identification assessment and appropriate services for more specialized health care needs and services to deal with disabilities or developmental delays.
What do the percentages refer to?
And the percentages here refer to my own relatively loose review of the literature, but also looking at the Future of Children's report on school readiness and looking at racial and ethnic disparities, where they tried to look at what you can do in different realms to narrow or close the gap. And when you look at what you can do if you are designing strong early learning environments, and if we were to make preschool available to all minority kids and really expand and intensify it, the best estimates are we could close the gap for those kids between them and their more affluent peers by 20 to 30%. If we were to look at comprehensive health services and providing those health services and doing clinically appropriate care and ensuring strong prenatal care and the like, we could close 15 to 25%. In terms of early identification, we can't close the gap for all kids. Obviously, kids with severe disabilities are going to continue to have. We can improve those, but early identification for a set can do a substantial amount. But what we know is, unless we address the environmental family factors, even if we do all these others well, we can't close the gap. So, you know, you can't avoid going to door number 3. If we really want to close the gap in results, we know we have to address these social determinants, and we know we have to do so by strengthening and supporting families in the context of their neighborhoods and communities. So those are kind of put up there as there's no silver bullet, no one entity which can do it all alone, but everybody does have a responsibility for doing that. And the health system operating alone is not going to close the gap, but it can do some things to narrow the gap. And particularly, and we'll get into this later, is it strengthens other support systems in their capacity. It can help to close the gap. And I'm going to use these 4 ovals and focus on the health oval as we go forward in saying, so what is the role of the medical home, and talk about the 5 C's. The literature, I mean, the health world has developed medical terms to talk about really this more holistic approach, talking about the life course model, talking about patient-centered care, talking about anticipatory guidance with parents, talking about addressing social determinants, talking about doing developmental surveillance and screening, and focusing upon child health outcomes, which when the medical world talks about outcomes, they really talk about outcomes in terms of their clinical outcomes versus does the disease exist, their functional outcomes, are people coping better, and there are outcomes related to people feel better about themselves, a fairly broad context. Early childhood terms are very similar. Ecological whole child approach, family-centered services, family engagement, risk and protective factors, early identification response, and domains of school readiness. So I think when we look at these medical terms, what we're trying to do through medical homes ideally, and really taking that whole child approach and addressing social determinants of health, we're doing things through the health world based upon a health literature of why it's important, but it's consonant with what's also been defined as important in other human serving worlds. And that means that if we're doing this in the health world and people in the early care and education world are doing this, and we're working with the same family, the family should be getting the same messages and supports, and at least we should be in line with our work. But it also points to where we can really work to connect our 2 worlds and say, even if we use somewhat different terminology, there are reasons for us working together. So unpacking the medical home's role as I've done it, is it starts with coverage. If you don't have a medical home, and if you're not having a child seeing a provider, there's no OVAL to begin with. There is a very important component of clinical care, what that child health practitioner does as their specific responsibility when the child is in the office with the family, and what that role is of the child health practitioner, the clinical care. They're responsible for that, and nobody else is responsible for it. There's also the coordination role that the child health practitioner often serves as the first responder or identifier of concerns that they may not be responsible for addressing, but they have a responsibility for coordinating to make sure that they are able to at least get that child or family to those other services in those other systems that are going to meet that child's need. The fourth is consulting, and those other systems are going to be responding to. You're going to have early care and education programs that are dealing with kids with special needs, be they behavioral needs, be they physical needs, and those individuals may or may not have been trained in serving those, but they're going to need, in some sense, the knowledge and expertise from the health community, and that can be conveyed in a consulting role. And then on a broader basis, there are a lot of things we need to do that are population-based and not individual child-based if we're going to succeed with kids. If we're going to address those social determinants, there are some things that have to happen at the community level and not just at the child level. So that's, and I'm going to talk about each one of these and what that implies for a medical home going forward. But first I want to bring up this one. I wrote out longhand because I think it's important, but I think that when we get to the real world, this is the type of situation that I think is extremely common and extremely important that we address. And that's a mom brings her 1-year-old in for a checkup, and it's pretty apparent the mom is stressed and not depressed, and she's not really picking up on the kid's cues and behaviors and connections. And the child isn't diagnosable today, but if things proceed as a medical practitioner expects, and if nothing happens to change what's going on with the stress of the mom and the interactions, they have every reason to believe that 2-3 years from now that child is going to have a diagnosable developmental delay or social emotional problem or DSM-4 diagnosis. The mom seems receptive to help and assistance, but she is pretty overwhelmed. And the medical home doesn't really want to wait 2 years to take action. The mom, as I said, the mom seems receptive to help. At the same time, pointing out that the mom has problems without offering help could be considered malpractice. So what do you do? And this is, whether this is 20% of all families or 10% of all families or 40% of all families, it's a big chunk of people who the health practitioner sees in their office. And sometimes they're not the primary health practitioner because there isn't a primary health practitioner, and it's just maybe it's an emergency safety net provider, a family qualified health center that come in with an illness. But anyway, here's a starting point. Here's an opportunity for action. And if it's not a medical home, how can it become a medical home? But then what can the medical home do for that child? And I want to come back to that case at the end. But that's the one I like to show, and when I show that to pediatricians or other health practitioners, I get a lot of nods. And I mean, and a real feeling like these are issues that I try to do what I can, but I don't feel entirely comfortable about often what I'm able to provide. And I do see people like this. This isn't one in every 100 cases. And particularly when we're talking about poor neighborhoods, it's a whole lot. So medical home, the definition of what is practitioner officer takes a partnership approach with families to provide care that is accessible, family-centered, coordinated, comprehensive, continuous, compassionate, and culturally effective. Maybe that is even from your definition in the code. I don't know. It's pretty close from your work. But the goal for coverage is really that every child does have a medical home, which is geared toward that. And I think that really Colorado has made tremendous strides in moving forward in this, making this available and a goal. And obviously there are a lot of people who, you know, it's a process of becoming more and more of a medical home once somebody even takes on that definition. And what I really want to point here is one of the keys is that continuousness, to the extent that you can be continuous, and particularly in that first 3 years of life when kids are being seen quite a bit, you really do have that opportunity of seeing developmental progress and risks and challenges as they go forward. So that's the what of coverage, and I said that's saying, do we have an oval at all to begin talking about? But when you have that in place, there is this clinical care definition, and right now, Bright Futures is the law of the land, according to the Affordable Care Act. My favorite piece of the Affordable Care Act, maybe the one that has the least teeth behind it to implement, but it's in there that it says now Bright Futures or evidence-informed guidelines by HRSA shall be provided through all health insurance plans, not just Medicaid. And that that means that primary, preventive, and developmental health services are an expectation for coverage and provision of care. And the goals really for medical homes are to assure that that children who come in really are assessed and treated to achieve those health outcome goals. And again, it's either on this slide or the next slide. Well, there it is. It's really this. This is what the practitioner can do. And
you go back.
Yep, maybe. Yeah.
I'll feel so embarrassed if I'm the only one. But Bright Futures is a particular federal program?
No, Bright Futures, I should have said that. Thank you very much. The American Academy of Pediatrics really partnered with the federal government to develop Bright Futures, which are guidelines. I think it's about this thick when it overall comes around for each developmental stage. I think it's based around well-child visits, what you should be doing in the practice to screen for and provide anticipatory guidance and when you should refer. And it covers behavioral development, physical, nutritional, and other concerns. It was developed by Paula Duncan and Judith Shaw and other practitioners, primarily, I think, in Vermont. I think it's now in its 3rd or 4th edition. But it really is, I would say, the American Academy of Pediatrics.
No, your question is right. But it's in the ACA? Oh.
Yes.
I heard you say it was in the ACA.
The Affordable Care Act, I think it's Section 2703 or something like that. I can give you the citation. Says that, requires that preventive care be provided without charge under health insurance plans.
Right.
And preventive care according to the evidence-informed guidelines established by HRSA, which means Bright Futures.
In the case of pediatrics.
In the case of pediatrics, right.
I'm with you now. Okay, thank you.
So, and it's, it's a wonderful document, and it's a wonderful resource, and as I said, and it has a short version that you can put in your back pocket as a practitioner, but I think it's a way we want to aspire toward, and what's been incorporated so far is the periodicity schedule for well-child visits, but there are emphases upon getting outcome measures that are going to do something to say, are you really doing this type of work? And anticipatory guidance is talking with families about their child and the child's development and providing them information and advice and guidance about anything that may be an issue or concern. And Ed Shore, who was with the Commonwealth Fund and is now with the Lucille Packard Foundation, who has really spearheaded the ABCD initiative and managed that, but has been really a leading pediatric practitioner supporting much more developmental preventive practices, came out with this at one point in time saying, we ought to say what are the outcomes for pediatric practitioners, I put medical homes. What should they be responsible for doing? And there's a longer list, but this is an abbreviated list that this is what we should expect from pediatric practices. Physical health, no undetected hearing or vision problem, no chronic health problems without a treatment plan, no undetected congenital abnormalities, immunizations complete for age. All those health things we know need to be done. In terms of emotional, social, and cognitive development, no unrecognized or untreated delays, which means developmental screening and surveillance. And in terms of families, capacity and functioning, that the parents are knowledgeable about their child's physical health status and needs, no unrecognized maternal depression, family violence, or family substance use, no undetected early warning signs of child abuse or neglect.
A high bar. That's a, I mean, that's a lot. That would be a big deal.
In some ways that's a high bar. In some ways that is, well, we should have a high bar. But these are all things that are, and obviously you can provide information to parents about their child's physical health status and needs. It doesn't necessarily mean they become knowledgeable, but you have a role in doing this. Some of these, I think, were italicized saying that you can't do it. They aren't totally within the purview of the practitioner, but others are, you know, you should be working and showing due diligence in doing all of these things. And if you start to say these, it broadens the focus much beyond what are biomedical issues and concerns. The third thing about medical homes is the coordination definition. And whether within the practitioner's practice or through some external care coordination function, and I know you have Healthy Steps here, which provides a lot of this, or health navigation or whatever, that practitioner who identifies that there are developmental concerns or issues, and our experience in Iowa is a lot of times we have a Help Me Grow project there. About a quarter of the referrals are for parental stress, saying that we know that example I gave you, that mom coming in, we know there's a problem, so we're going to refer that family to a care coordinator, or in other words, we're going to call the care coordinator. They're going to get in touch with the family, and they're going to talk with the family and find out what it is. And I think really the goals for this is the practitioner is not going to be a child development specialist in all cases. Not all practices, although some like Healthy Steps, can have in-house people who do this work, but there has to be some follow-up that really gets to where the family is and what is going on in the family's life and what supports may be available, and that children and their families will be referred to needed services, but appointments are scheduled and kept and results are reported back to the medical home. And that's one of the things, and I think I have a slide on this around Help Me Grow and its own model, but it's not just referring, it's also making sure that people find their ways to something. The experience from Help Me Grow is that the care coordinators, I mean, in Iowa and other things, may make 6 or 7 calls to different resources in the community in order to find something where there is an availability and they can schedule a meeting, or schedule a visitor, find an open slot. If you ask families to do that, that's a tremendous burden, and doing that, and then the feedback loop to the medical home is key. And here is where that kind of coordination link, when you say the practitioner's office is not going to provide parenting education classes, it's not going to secure an environment for the family where they really do feel safe, but there are other places out there which are going to need to do that if we're going to achieve health. So how do you do that coordinating role? And this is the representation, and the health practitioner or the medical home doing the screening and surveillance. And there are a lot of tools, and obviously under Medicaid and under some private health insurance, and depending on your system, you can do developmental screening and get paid for doing ASQ or PEDS or other types of things. Well, one of the findings from Help Me Grow, which is the Connecticut program, which has been around for a long time doing this, is simply asking the parent, do you have any questions about how your child is learning, behaving, or developing? Or do you have any concerns? Often elicits something you can then build upon. But to do that, to do developmental screening, then to have some care coordination, which could lead to home visiting or could be even through home visiting, which would engage the family and help the family and secure and identify where the family is and what would be helpful to them in the way of services and supports, and then secure professional services and community supports and provide the practitioner with feedback. And then the community resources and connections in Help Me Grow as a model, and people now talk around community utilities, but you have to know what's out there in the community, and those communities have to kind of be geared towards getting referrals and connecting up, and may need support to know how they can be part of the system and getting back. That can be Part C child mental health services, an immunologist, home visiting, Head Start, a domestic violence center. It can be formal services that are out there that are really needed. It also could be a peer support group for grandparents, a parent for children with ADHD support group, a Hispanic resource center, or a church family night program. The experience from the Help Me Grow, which is now being replicated nationally, I know Colorado is beginning to be a part of that as well, is that often there's a need for a referral to a professional service and a strong link, and if there's a developmental disability, to be able to navigate to Part C or something else if that child's not Part C eligible. But often that is only part of what should happen, and that bottom row ends up often being something that's very important, so that the family is connected with something other, and that builds back to social determinants of health and social connections and ties, and a sense when families are stressed and isolated, if they can be in social and supportive environments with others. And I put down parents of children with ADHD because often it's affinity-based networking that's important. That can make a real difference. And these bars going back and forth. One of the experiences from Help Me Grow is that practitioners, to get them to make referrals to a care coordinator, they're used to referring to a subspecialist and actually having the family go to a subspecialist or the child go to a subspecialist, and the subspecialist provides a report back. They're often not, if they've referred people to CPS, they don't know what happens. If they refer people to Part C, they may not know what happens if they know where to refer. That closing that loop and getting the information back to the practitioner is really important as well, so they know something happened. And they may even be able to, they'll probably put it in their chart, and they may even be able to refer to it when they see the child and family for the next well-child visit. So it's closing that loop. Now, for the health and well-being of children, on many of these issues that don't relate to biomedical services, you could really have just 2 and 3 if they were really well-functioning operate, and do that if families ever get to that care coordinator. But for particularly for young children, I'll stress this again and go to it. For 0 to 3-year-olds, 90% do get to a child health practitioner for a well-child visit every year, 0 to 3. 15% are in some formal child care arrangement. And by the time they get to be 3 to 5, it's more like 50 or 60% are in some formal child care arrangement. But when kids are very young, they're in family, friend, and neighbor care with relatives, which is very predominant, or the families try to fend for themselves. Infant and toddler care is not very available, nor is it in a lot of cases the preferred choice for families, and doesn't necessarily fit what the family schedules are. So families are struggling. So the child health practitioner is the closest thing to a universal point of contact, and that's why they play a pretty important role in this referral. In terms of consulting, and it really does get to integrated plans across service systems, respond to treatments. Probably a lot of you have heard of the studies of the number of kids who've been expelled from early education programs and Head Start programs because of behavioral problems and challenges. And of course, those are the kids who are most vulnerable and most benefit from being in those environments. And yet they're the ones that those providers tear their hair out and don't feel capable of providing care for. And they show up in schools, and schools have to take care of them, but sometimes they refer them to special classrooms and the like. But that child, or a child who is simply withdrawn, may not be a problem, but how does that, I mean, in terms of behavior management, but how does that program know how to draw them out? And it's there where clinical expertise is really important. And obviously there are mental health consultants and health consultants to child care centers and programs that can play some of this role. But the child doesn't stop having health or behavioral or medical needs after they get outside of the doctor's office. They are going to manifest those in whatever environment they are, and there are roles for the child health practitioner to equip them to serve there. And so that's really also a role that the child health community can play, and public health practitioners can play in particular. And the final is medical homes. I think, you know, by medical homes are sources of seeing kids over a continuous period of time, and families, and knowing those families, and often knowing them in the context of their family and neighborhood and community, and really can be part of that community in providing guidance and support and responding to population health concerns and advocating for community action. So medical homes can contribute to that community understanding and health needs. And I get excited when I go to federally qualified health centers in inner cities, which are really hubs of community activity and have a variety of activities going on in them, and are also ending up doing radio programs and having information going out to the broader community on different health concerns and issues and what to do. And I think that that's a real role. So that's kind of conceptually, I think, where the medical home plays out in the early childhood world and where it has real opportunities of moving forward. From conception to practice, I think that really is an issue of resources and adequately financing medical homes and defining their responsibilities and financing that care coordination that leads to effective referrals and consulting. And I think we have new opportunities too in the ACA to do that. And in fact, One of the features of the ACA is under Medicaid raising primary care reimbursement rates to Medicare rates, which is, while still not full, it has provided a substantial bump up for primary services, and I think is a key, and as I'll show in a couple of slides, this is where a lot of the kids are, particularly young kids are in Medicaid programs. A second thing is diffusing effective practices, really being strategic about creating an impetus for change and diffusion, and we talked around health equity, and I think a lot of the things that you're doing in terms of trying to broaden out the use of medical homes, but also trying to go deeper in some communities is really supporting those champions in those communities to go deeper, and really looking at how you can make it possible for them to draw outside the existing financing and regulatory lines to do what they want to do, and then move as quickly as you can to say, now that they've drawn outside the lines and show how it's worked, how do we reconfigure our lines so other practitioners can do it as more of a standard basis of practice? And that's really the strategy around diffusion, and really developing where you do create these to really showcase what the successes are and really look at those, closing the gaps in child health outcomes. So I want to go on to, I think that there are tremendous opportunities now, and I think your work in Colorado is great, and I think that obviously there are federal roles as well, and to draw upon federal support. I wanted to put up this slide around estimates about how much the federal government contributes in its funding. About 1.6% of the federal budget goes towards children 0 to 3. And the President's new proposal for preschool and a range of things, including early Head Start and home visiting, which gets into the realm, is works out at $10 billion a year, and that would add another 0.3% to that equation. But that's important. But we're not investing. I mean, we have an investment gap, but we still have significant investments. But if you look where the money is going, Medicaid, $21.4 billion. That's not supposed to be million. That's $1 billion at the federal level. And the percentage of the population nationally, according to EPSDT forms, 56% of all kids 0 to 2 are EPSDT eligible under Medicaid. That's according to state reports under their EPSDT forms. I think it really surprises people when they see this number. But when you look at overall children, it's a lot lower because there's a lot lower rate, and I'll show that in a minute, around younger children. If you look at WIC, which is really the second largest source of contact with young children, 4.9 billion and serving about 28% of all young children. And again, there's a great opportunity there around the nutritional counseling and support to work with kids. If you look at the child welfare world, foster care and adoption assistance, about $500 million, and it serves 1% or less than 1% of the population is actually in foster care, very critically important 1%. Part C of IDEA, again, I think early intervention is very important. I think that we have to distinguish between intervening early and what are the current capacities of early intervention to achieve. If you look at the national research, probably 12% of all kids would qualify under most state definitions of early intervention, not even without the environmental risk, but in fact, nationally 2.8% of all kids are being served by early intervention. If we're going to really reach that broader population to intervene early, we have to find something either to bolster Part C and dramatically expand it. In some states like Massachusetts have done that, and they serve about 6% of their kids in Part C, but most states serve about, the average is 2.8%. Child care and TANF funding for child care, again, it's $4.4 billion. About 4% of all kids 0 to 2 are actually in that system. Early Head Start is 1%. And McVieve, which is a maternal infant and child health home visiting program, again, I think this can be an important wedge at the federal level, and certainly its resources are to be valued. I think you probably put in a lot more money at the state level in nurse-family partnerships than actually the McVieve money coming down. But it's right now $200 million, and serves a little bit less than 1% of the population. So the major sources of funding, and the Maternal and Child Health Block Grant is about $600 million. And again, I think if that's used strategically, and a lot of that's used to bolster leveraging other resources, as Part C dollars are, it can really do something important. But the big item where kids, I think, when we're talking about medical homes, it really is within Medicaid and thinking strategically around how we can address children in Medicaid.
So those are all million except for the first one?
No, they're all billion.
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 All billion.
They're all billion. I think when I was doing that slide, I was thinking about states and not the federal government. You always add a few zeros, yeah. Where we are today in child health coverage and Medicaid participation, in terms of nationally, and all this data is available for Colorado too, that I'm presenting here, and I think I have it in something, but I didn't put it on this slide. 0 to 17 uninsurance rate is 7.5% for the 0 to 17 population. If you look at the population below poverty, 200% of poverty is 10.7%, which obviously is a concern. Like if you're looking at that, even having the oval, we have a ways to go. We're better off with respect to young children. There's a higher rate of insurance for young children because of Medicaid coverage, and the National Center for Children's Health survey for 0 to 5-year-olds indicate that 4.6% are uninsured of young children, compared with 6% for older children. So that's obviously below where the top figures are because this is parent reporting. But it gives you an idea that we're better off with our uninsurance among young children, but we still do have something that we have to do if we want to get to all kids. But the last three are really from the 416 forms, and it shows that for 0 to 2-year-olds, 56% are enrolled in Medicaid according to state reporting. 3 to 5-year-olds is 51.5%, down to 6 to 17-year-olds is 35.6%. When you look at, for those who are actually enrolled, the number of EPSDT or well child visits that they have, for that 0 to 2-year-old population, it's 2.2. And that's obviously not the recommended number that for screening them that year, but it really is the time when they're seen. If you look at the average number from 3 to 5, it's 0.71, and average number annually for the 6 to 17 is 0.42. And of course, you're not required to go in every year, going up to age 15 to 18 and so on. But this really says, medical homes, number one, is we really should be looking at the Medicaid population, but particularly the role of a Medicaid home in terms of that primary first responder and identifier and surveiller to respond to both biomedical and social determinants of health is going to be in those critical 0 to 2 years.
I wonder in the states that there are some states that have a requirement, a school requirement for a physical exam, not just for athletics, but periodic physical exams for schools. I would wonder if that bottom area, the 6 to 17, has a higher,
It could have. It could have.
We don't have any requirement. outside of school.
This is, this is the good news. I think that we have a place to go. The next slide is also from the National Survey of Children's Health. And I don't know how many of you have looked at the National Survey of Children's Health, but it just came out, the 2011-12, and they actually asked some new additional questions on this one. They asked around family stress. They asked around whether or not you had, you experienced, challenges raising your children and other things. But they also reported on these. Reported having a preventive well-child visit in the past 12 months. Again, for children 0 to 5, they didn't break it down 0 to 2 and 3 to 5, 90%. So we're saying, yeah, kids are really getting in and being seen. That doesn't mean we don't try to get to that other 10%, but it does mean this is a pretty good point. As far as the child reporting having coordinated ongoing comprehensive care within a medical home, 58.2%. I think we still have a way to go. I don't know how they asked this question over the phone, but children reported as having been screened for at risk of developmental behavior and social delays using a parent-reported screening tool during a health child visit. But that really means our kids having something like ASQ or something like PEDS being provided, and the parent actually recognizes that that happened and that they are being known. And this was just for the 10 months to 5 years, showed 30% of parents reported that. So I think that that's probably higher than it was 10 years ago, but it does show that if we really want to realize the goals for health homes and medical homes, we have these as benchmarks that we want to see change as they go forward, and the next child health survey exists in 4 years. And again, this data is available on a state level, and all of the data can be broken out by child age, and it can also be broken out by income level, below 100%, 100 to 200, 200 to 300, 300 to 400, 200 to 400, 400 and over, and it can be broken out by race, ethnicity, at least by white, non-Hispanic, Hispanic, African American, although for some states the data is not enough in some of those populations. It can't really be broken out by just in many cases by just the 0 to 5 population of those variables, but it can give you a wealth of information, and particularly around that social gradient, it can really show you a lot of things. So I think, that as we move forward and we look at Medicaid and EPSDT opportunities in supporting children birth to 3 or birth to 5, and we can look at, I think, financing. I've been involved for the last 3 years with a Medicaid EPSDT working group that was put on, which was assembled by the Center for Medicare and Medicaid Services and under Cindy Mann, and it involved a lot of champions for promoting broader visions of child health. I think people like Sarah Rosenbaum and the folks who did Bright Futures and the folks from the Georgetown Center for Children and Families and AAP and others were represented. And they have really tried to work to provide more guidance to states on what states can do rather than what states can't do under Medicaid. And but I mean, I think that there is more openness and more push, but certainly under child health practitioner roles, there are opportunities to do developmental screening and surveillance. There are billing codes to bill separately for that, to provide on kind of, in Iowa, I think we provide something like $45 for a screen, which is pretty substantial and certainly is enough to get practitioners to do it. And I think in other states they also allow that to be provided to even outside the medical practices if it is done in other types of care settings. But that's a real way of doing that. that referral for medical necessary services, that there are opportunities to even cover an increasing array of services, and many more states are finding ways of covering at least some aspects of home visiting for populations under Medicaid. And there's even a Medicaid circular on how patient support groups can be covered under Medicaid. So I think that there are new openings for covering some of the things we know are working, and particularly around care coordination, there are opportunities for providing that coverage. There are certainly opportunities for covering training and support to practitioners so that they do developmental surveillance and screening and they make referrals. In terms of care coordination, I think that that can be covered, and as you have healthy steps within a practice, they can also be covered as a freestanding service or as a community utility. They can be covered as a direct service or as targeted case management. They can be covered under a per member per month fee that would enable to develop a center. I think that there are a lot of locations for that. And the Medicaid statute does say that they're supposed to be provided in a way that is administratively simple and doable, although often I don't think it necessarily gets worked out that way. But you can make those so that they are accessible. And that can include doing that motivational interviewing and whole child approach. I think that there are also a lot more opportunities, and there will be under the ACA now that parents are covered as well, but programs, one of my favorites, Child First in Connecticut, which does a lot of work with families who are struggling and whose mothers may be depressed or extremely stressed and have limited skills in terms of child development, for doing home visiting and dyadic treatments around parent-child bonding and relationships development, and providing funding for that, which involves not a specific child service but one to the dyad, and can cover the range of things that go into providing guidance to the parents as well as to the child, even under the child's billing. I think that there are a lot more opportunities for doing that. When I look at maternal depression, which we obviously know has huge impacts upon child development, I think if we treat the maternal depression, there's going to be more positive bonding and relationships, and the child's health is going to improve. Sometimes if the child is acting out, that's creating stress and depression among the mom, and if we address the child's behavioral issues and concerns, that can do a lot for the parent-child relationship and health. And if we just focus on helping the child and mom and child in that relationship and build upon that strength, that often improves the child's mental health as well as the kid's physical development. And in fact, that relationship and support for that parenting, education, and support and nurturing and bonding and attachment is something that is at least coverable in some ways, and I think states have to be really concerted in trying to make sure that does get covered. And in terms of community services, some of the services that existed in that diagram around Help Me Grow, certainly that top tier of services often are coverable under Medicaid. And I think we can look a lot more at how those can be covered. So when this is what's needed to really improve the child's healthy development, it is medically necessary. How can we get it financed? There are going to be some of those community services which aren't, but I still think that it fits into our role of how do we develop people out there in the community who know and can navigate those. So I think that there are a whole lot of ways that we can support medical homes, strategically. I think that I was recently on a panel with someone from Massachusetts who worked with Part C there, and been doing it for 15 or 20 years and is a champion. And they now cover, I think, about 5.5% of all of their kids under Part C. So they've really expanded it. And I think they get about $10 million from the Part C program. But their program with Medicaid financing and with private health insurance is really a $150 million program, because they've leveraged that support. And not only did they started with Medicaid, and they got financing for services under Part C under Medicaid, but then they were able to use that to leverage equivalent or near equivalent support from their other health providers. And Massachusetts is a little easier state probably to get mandated benefits than it is in Colorado or Iowa, but it's still, I mean, eventually the more we do, and if we're looking at half of our kids 0 to 2 or even 40% being covered under Medicaid, and then you think those are the most vulnerable kids, we're probably talking about 2/3 of the kids for whom we are really, if we can provide these care coordination services, if we can address those behavioral developmental needs, if we can do that coordination and consulting to really create those opportunities, we're 2/3 of the way there. If we can push Medicaid to do that, ultimately I also think then we have real powerful arguments to push the private sector to follow along. And this is what happens after the fruit in our work, I really think, is if this mom comes back after 3 years and she comes in with a 36-month-old for a well-child visit, and her daughter's looking forward to coming knowing she'll receive a free book, and excited to tell the nurse she'll be going to Head Start next month with her best friend. The mom has an ASQ form and a set of questions for the practitioner about her daughter, who's already starting to read but mixing up letters, and she's wondering if there's dyslexia. And the mom is in a mutual assistance group, and she wants the help from the practitioner in getting more dentists who will serve children in their community. I mean,
Yeah, that's a good question.
and maybe that's pie in the sky in some ways, but you know, it really isn't. If that mom does get connected to some of those supports, in some instances that's going to be happening, and I think that's what we want to be. Those are the stories we want to be able to tell about our work, and that's clearly not going to be for every family, but I think that at least from our work in Iowa and our look around the country, when you look at exemplary programs and practices, you can really see some of these stories coming out. When I gave this presentation in Iowa, one of the people there was the head of the primary care center, which is a federally qualified health center, and Mary knows him, Barry Ingebretson. And, you know, and he said after I gave my presentation to me, he said, you know, when you started this presentation, you told me that story of that mom coming into the office. I thought, I give her a book, and from Reach Out and Read, and then I call First 5, which is our Help Me Grow program, and I wonder, you know, is that enough? And now you're telling me I did the right thing. And I mean, and I think that one of the things there is that if you say that the practitioner is responsible for everything in the world, it's not going to happen. But if you say you can really start the process, and if you have that care coordination and the referrals and links to community services, and if you can kind of like the next time the mom comes back in, you can ask her about what went on and happened, and you can see that child, and you see that child over 3 years, this can be your reward. That is a tremendous buy-in. So we have a bunch of different publications that say sort of this in different ways. We're happy to share with you. The Healthy Child Storybook, it's on our website, which has a lot of program examples of best practices, as well as kind of setting the context for how to do this. I did a piece with clinical care and community building with Ed Shore that speaks to both that role of the practitioner in their own work, but also in their community building role. The paper we did last time for medical homes and early childhood systems building, and a compendium of how different players can improve child health that we're happy to share with you at any time. I know you're doing a lot of this work out there in the field and in practice, and I think that one of the things that is really important is to showcase your successes. Steve Poole was at our meeting and obviously has been doing this. Angela Soia was as well. I think you have certainly pockets of excellence out there as well as energy to move forward. I'm just looking forward to your moving forward. I hope I can be helpful, and I hope providing this is a context. I think that we do have to continue to explain this work to other people who may not be as versed in it as we are, and part of this presentation is really designed with that in mind and to provide you with the ammunition for doing that. So I'm ready for questions and comments, and I haven't looked at the chat room, but there may be some that came in too, but you have a...
As I saw Dr. Jeffrey Bruner speak this morning in Aurora, he did that pioneering work in hot spotting in New Jersey.
Do you want to come up here and talk into the microphone? Because we have like 35 people.
Okay.
I'm sorry to disturb you, but then I won't have to repeat your question. I appreciate it. Thank you.
Well, Dr. Bruner, he liked what we were doing out here also, and he wanted to move Camden, New Jersey to Colorado. But he mentioned hospitals and big pediatric institutions interested in market share and increasing volume and this kind of thing. And I was wondering about your thoughts on the relationships with hospitals and private pediatric concerns, and what kind of relationships you may have with them.
Yeah, that's a good question. One of the things I would say is right now there's a lot of emphasis in the medical world on developing accountable care organizations and meeting the triple aim of improving health quality, improving population health, and controlling per capita health care costs, with a lot of the emphasis on controlling per capita health care costs. How can we do a better job in serving people? And there's a lot of the health transformation work right now focused on this, and accountable care organizations. And if they're going to be more than a repeat of managed care entities, I think it's really important to have the practitioner involved in this. But I think that when we talk about pediatric practice, what we have to say is that it's really important, and there are savings to be gleaned from young kids and chronic health conditions, and particularly neonatal costs or addressing prenatal costs that are there that we need to look at. But a lot of the emphasis from this accountable care organization work is going to be on those who are already high-cost users of the system with chronic health conditions who end up being in and out of hospitals for care. And I'm all for better diabetes management of 68-year-olds, and that's really important. And I think that there's a lot of savings to be gleaned. And the $1 Million Murrays, who are frequent users of crisis-oriented care who could be treated better, are really important to deal with. But kids, I say, they're not the drivers of the health system, but our future in chronic health conditions is going to be determined by how well we develop kids. So they're not the drivers of healthcare costs, but they're solutions down the road if we want to do something. So somewhere we have to look at what we're going to do to change the trajectories of kids and how we're going to use some of this emphasis upon accountable care organizations, not to look at healthcare costs over a 2-year period, but over a 20-year period. And if we can do something there and say, let's have some of this savings be then redirected, shared savings, towards doing something that is going to have long-term impacts upon kids. And hospitals can be big contributors, but if you look at kids 0 to 5, there are kids with chronic health conditions. There are kids who end up in hospitals. There are kids who end up in emergency rooms. But it's a pretty small fraction of the population that we want to do things, but it's more about addressing their needs and their healthy trajectories so that they don't get into positions as even 5-year-olds or 12-year-olds where they have type 2 diabetes, when they have other types of things that are now going to be, and now we're seeing an increasing morbidity among children around some of these conditions that emanated from the young child. So the kind of message is, I think hospitals can play a role, but I don't think we want to leave it to that. I think also when we look at this triple aim, improved quality of care, improved health outcomes, and reduce costs, if we go to hospitals and their mechanisms and their administrations, they're going to look at the cost containment angle. And we need some people who are champions around the health improvement outcomes angle. And I think that's where we get into the child population and the child practitioners. In terms of hotspots, I really look at those hotspots about where you can find who's serving the kids today and who are those trusted providers of care, which may be, in some instances, emergency rooms, and they may be safety net providers, and they may be the federally qualified health centers or rural health centers. How do we work with those folks and say, how can we make sure that they can do all they need to do in those neighborhoods? The last thing I'll say, I give long answers to short questions, but when we're looking at hotspots, we're really looking at areas which have high concentrations of low-income kids or adults with often a lot of chronic health conditions and poor health outcomes. If you look at the profiles of those neighborhoods, generally they're rich and young children. They got a lot of young kids, and they have profiles where their parents are just as likely to be working in as more affluent neighborhoods, but at a lot less level, with a lot fewer resources to invest in their kids, with a lot less education, with a lot fewer role models out in the community, and a lot less expectation of opportunity. And if we're going to address those hot spots, it is about getting them health care, but it's also about working with them to make sure that they feel and they feel they and their kids have opportunities for the future. So it's really even more integrating the health world with the other community support systems in the neighborhoods. And to the extent that hospitals and federally qualified health centers can be hubs of activity around those other things, that's great.
Is there anybody that needs to be addressed in the chat room? Or I guess we've been talking to them all along, huh, Annie?
So Gina shared some comments.
Okay, well, Gina Robinson is with us by chat room. And she, first of all, we were being asked if slides are available or will they be, and we can send out the PowerPoint to the participants after today. I'm sorry those weren't made available earlier. And Gina has Colorado screening information for Medicaid eligible kids on billings. So Gina says that our rate is a bit higher than the Child Health Survey, and she's wanting to remind Charlie to send the ACA reference to Bright Futures when you send the slides. So we can do that too. We can send the Bright Futures references as the resources.
I think she wants the reference specifically from the ACA that names Bright Futures.
Oh,
but it does not name Bright Futures. What you said in just means it.
Yeah, evidence-informed guidelines adopted by the HRSA, but that is Bright Futures.
So you can send us that citation if I
Yes.
get back to you. Okay.
Anyway, actually, I have a question. Do you think that states are interpreting it the way that you are interpreting it in terms of HRSA guidance being Bright Futures, or do you think states are taking liberties with that interpretation from your discussions with states?
I think that they're interpreting it as being Bright Futures. I think that often Bright Futures is narrowed down to, it's a phone book. It's a Bible for, it's an authoritative source on everything. It's not one page that says you have 7 visits during your first year and so on. So I think that they're probably functionally doing that. I think that, again, I think it's something that it's as powerful as we use it to move things forward. The federal Medicaid, when it was established the early periodic screening, diagnosis, and treatment for kids, I think recognized that health systems, generally health coverage in the private sector, was not geared toward children. It was basically an adult health coverage system that provided for some forms of treatment of illness and injury and a little bit of health maintenance, and assured that when people got sick there was a source of coverage. It did not look at kids as actually developmental beings, and we needed something different. And so early periodic screening, diagnosis, and treatment was established within Medicaid. And it says that, it's fairly short, but it says, I have to provide early periodic screening, diagnosis, and treatment based upon medical necessity, with medical necessity going beyond what is simply in your list of things that you currently cover, but it's what's necessary for the child's development and health. And states are given the responsibility of defining medical necessity. As a statute, it creates that opening for providing very comprehensive services. I think it's often EPSD without the T, and it's been used by advocates as a litigative tool. And I remember, and I went back and forth with Sarah Rosenbaum, who was probably responsible for EPSDT being in place, and just a wonderful advocate for kids, and really worked on it, because my own government was saying EPSDT is paying for swimming pools for people. And, kids who have developmental disabilities and require therapeutic interventions, and they're recommended some water therapy. So EPSDT is, there's some place where they were required to pay for swimming pools. So I emailed, do you know about this, Sarah? Where are these swimming pools? And it was obviously an urban legend. But I really went out and I was looking at what has been the litigation around EPSDT. And there's been a lot of litigation around EPSDT around covering diapers for kids with special health care needs who are 15 years old and need Pampers. And there's been litigation around mental health services. There's been litigation around dental care, but didn't find any around swimming pools. But saying that, I think that there's this feeling like if we open this up, we're going to have all these things that people get. And when I've talked with Medicaid directors, even those who are really supportive, you know, would like to do the right thing, I think what sometimes they say is, we have a lot of things we know need to be done that we're not covering. And now somebody's coming in and suing us and making us do something. And we're not really bad guys, and we don't like being sued, and some court rules we have to do this. That's not on our biggest wish list. And litigation is never the preferred way of getting something, but sometimes it's the necessary way. So EPSDT has been used as a wedge by advocates, sometimes through litigation. And I think that has also made it sort of seem an oppositional force. That's why I really hope that some of the guidance letters, which I'll also get to you, make available to you from CMS, which are around integrated services and patient-centered medical homes, what you can do under EPSDT, I think are important, because I think people have to have the feeling that if they do something at the state level, they're going to be supported. But EPSDT is it's on the books, and it's the law of the land, and it's what you have to do under Medicaid. But that doesn't mean people do it. It takes some push to get people to really make use of it.
There's another question here, Dr. Bruner. In states like Massachusetts, where they have figured out how more children can be served by Part C, are they seeing any tangible or measurable impacts, such as cost savings or improvement in school readiness?
I think that they are, and I'd have to look that up, and I think that's a really important question to try to be able to document. I think particularly around the demonstrating measurable impacts. And I think one of one of the goals of one of the goals of Part C is that kids don't end up in Part B, right, and they don't have a need for Part B services. And I think that there are some potentials for long-term impacts and savings.
So I'd add to that question, when they're figuring out how more children can be served by Part C, then they must have more state dollars that are helping the Part C, because more kids are becoming eligible, because the federal money for Part C services
right.
is diminishing.
They put in state dollars, yeah, but they've also leveraged, the big leverage has been around Medicaid, which of course is part state dollars, but then and the private insurance. I think it was something like $60 million in Medicaid and $30 million in private sector.
So they make the eligibility criteria greater then, so that kids, it's not as hard to get in?
Well, they have a broader definition, and they're 30% developmental delay on one factor, and different states have different dimensions. But at least my experience is it is an entitlement to service, but if it's financed with a fixed amount of funds, it still is people are going to end up doing things at the local level that enable them to manage within the number of folks they have and do. And I mean, and one effort is to try to increase demand, and I think that the requirements around Part C for kids in foster care or protective services is important, but you still have, and I mean, for a long time, I mean, in Iowa, our Part C program is saying we're in a time when we serve everybody who's eligible. Well, but do they really do outreach to try to get those individuals? And if you look at the patterns at the time, it was we did some census tract analysis and some other stuff, and we found it tended to be, there tended to be slightly more people who were from upper income census tracts and lower income census tracts who participated. Even we know that's not the case, and and it really is, like assertive professional parents who know where to go, who have concerns around their kids, get service. That doesn't mean that those who are
it's not addressing any of those other social determinants that you were speaking
right,
of earlier.
Yeah.
It could, in some cases, due just to the eligibility criteria for Part C for the developmental delay, just
Yeah.
as they have.
But our state was saying we're serving everybody.
Yeah.
Yeah, and what they're saying is we're complying with the letter of the law of being an entitlement program. We're not saying we have a waiting list, and we are getting around and we're meeting these guidelines. But given our resources, that probably means that whatever our developmental delay, we end up defining so we don't end up with an.
Right. It's close to 6. Does anybody have any burning questions in the room or in the chat room for Dr. Bruner? I must say that it's just a pleasure to have him. He has been here in the state of Colorado for 2 straight days at a different conference that was quite demanding, I'm sure. And I asked from afar if he would come and share with us his expertise. And he said, sure, but I bet by 6 o'clock you were, on that second day, you were pretty much done with conversing. But it's been.
Well, my spouse arrives at 7:30, and we're taking a trip out here for the rest of the weekend, and we're not going to bring any of this stuff with us. So
Oh, good.
we're going to take advantage of being in Colorado.
Oh, that's so nice.
Yeah.
That's awesome. Yeah. Well, again, I really want to thank you for coming, Dr. Bruner, and sharing your time and expertise with us. It's just been wonderful. And we'll follow up with any questions that people have. You can address myself, Jane Gerberding, or I'm certain that Dr. Bruner would probably take a question or two at his email there. And we'll make sure to get you the PowerPoint and some of the things that have been asked for during the presentation. So thank you all for joining us.